So our next speaker, it's actually, when you look at his bio, we continue with the Switzerland link here. Dr. Packard did his initial college training at College Voltaire in Geneva, and then he graduated medicine at the University of Geneva in Switzerland, so we have a good link there. He then came across the pond, I guess you can call it, and he did fellowship training at Brigham and Women's Hospital at Harvard, University Hospitals of Cleveland, and did some research fellowships, won some awards for the stuff he's done. So we're going to get a very interesting discussion here. Dr. Packard is presently assistant professor of medicine, physiology, and bioengineering, which is an interesting combination for an imaging cardiologist, I must admit. And he's at Ronald Reagan UCLA Medical Center, as well as the West LA VA Medical Center. And we're looking forward to his talk on fluorine 18F-Flurpiridaz PET imaging and myocardial quantification. Dr. Packard.
Bonjour tout le monde, je vais juste dire quelques mots en français. D'abord, j'aimerais remercier le docteur Lamoureux ainsi que le comité organisateur pour l'invitation. Ça revêt une importance tout particulière pour moi parce que lorsque j'étais étudiant en médecine à l'Université de Genève, mon premier stage à l'étranger était à Montréal. J'ai fait 2 mois de pédiatrie à l'hôpital Sainte-Justine. J'ai passé un moment merveilleux ici et j'ai appris 2 choses pendant ce stage. En premier, que vous avez vraiment une ville absolument magnifique que j'aime énormément. Et la deuxième chose que j'ai aussi appris, c'est que je ne deviendrai jamais pédiatre. So, good morning, everyone. I'll be talking to you about myocardial blood flow quantitation using fluorine 18 labeled Flurpiridaz PET. I have no conflicts of interest. So I think any study really in relative perfusion cardiac imaging and also myocardial blood flow quantitation imaging, and similar to the slides Dr. Pryor showed you, has to mention Dr. Gould. I mean, the work that Dr. Gould did half a century ago now was really seminal and really paved the way to our understanding of the physiology of coronary artery disease, and also paved the way for myocardial blood flow quantitation. And there's always, from time to time, a titan in medicine that emerges. It really lays the groundwork for work to be done for decades, and Dr. Gould is certainly that person in our field. And I just want to acknowledge that this is a study that was done in dogs, and you can see on the top part of the panel the reaction to a dog that didn't have any coronary artery disease, in this case induced by ligation. And on the bottom panel, you can see changes in flow. This is measured with an intravascular catheter at the time, and you can see a decrease in flow, and also based on the studies he did, a decrease in relative perfusion. So myocardial blood flow quantitation by PET. From regions of interest assigned to the LV blood pool and the LV myocardium on serially acquired images, time activity curves are derived that denote the alterations in radiotracer activity as a function of time. Through fitting of the time activity curves, and there's a lot of biomathematical modeling that goes into this, with the operational equation formulated from tracer kinetic models, blood flow is obtained in absolute units and reported as milliliters per gram per minute. So here you have like an example. This is a paper by Dr. Schindler, who has done a lot of work in this field. And in green, you can see the arterial blood pool, typically measured at the level of the LV cavity, but it can be elsewhere. It can be in the left atrium. And then you have the LV myocardium, meaning the uptake of the tracer by the myocardium. So rest myocardial blood flow, typical values, and this may vary a little bit based on the tracer you're using. I understand in Canada, it's rubidium 82 chloride. In Europe, they also use oxygen 15 water. In America, we use also N13 ammonia. But in general, in patients with normal coronary arteries, a resting blood flow is typically around 1, give or take maybe 0.2 or 0.3 mLs per gram minute deviation. In normal patients, you'll have an increase in your stress flow, typically that's like 3 to 4-fold. So then the ratio of the two is what allows you to calculate the myocardial flow reserve. And that's the ability, really measures the ability of your myocardium to increase blood flow in response to stress. And based on the numbers above, you can calculate that the typical myocardial flow reserve in a normal patient is around 3 to 4. What exactly constitutes an abnormal cutoff is a little bit equivocal, but typically what's used in the field is a value of 2. So if you have a myocardial flow reserve that's less than 2, it starts heightening your suspicion of either flow-limiting ischemia or diffuse microvascular disease. So before you jump into Flurpiridaz, we need to look at quality control, and this is true for any tracer. So you need to make sure that you have a good injection, a good uptake at the level of, a good quantification at the level of the LV cavity, which is the spike you see, and then uptake at the level of your regions of interest as derived from the coronary distributions. So most centers actually still don't quantify flow. Certainly, we looked into this in the United States, in part because a lot of centers have old scanners, which are maybe not as well equipped to quantify flow for various reasons. But so typically what you can't afford to have is a scanner acquisition that starts late. If you miss the early kinetics, that messes up the biomathematical modeling that I was alluding to, and you can't derive accurate numbers. Another issue, again, with the older scanners is if you have a saturated signal. So if you have a saturated signal, you're going to miss your true peak, and that's again going to mess up your modeling. Any patient motion or even heart motion or motion due to respiration will lead to problems. Most of the softwares, I should add, nowadays correct for that. But if you have really important patient motion, it will still mess up your kinetics and your myocardial blood flow quantitation. Another phenomenon we described, this is true in particular for adenosine stress. I think it would also be true for dipyridamole, but it's less true probably for regadenoson stress, is this effect of that we described as myocardial creep, where you have a slow shift basically in the location of the heart compared to your region of interest. So this is something that you need to adapt maybe over time during the acquisition. So the utility of blood flow quantitation by PET. So flow quantitation provides incremental information in situations where relative perfusion has no limitations. It compares the relative perfusion of the most diseased territories versus the territory showing the highest perfusion, which itself can be abnormal, leading to underestimation of disease. And Dr. Pryor showed us an example of a patient who had 3-vessel disease. That's basically the most critical patients that you'd be missing if you look only at relative perfusion. And quantifying blood flow allows you to unmask decreases in blood flow. The other thing you look at is microvascular disease, which is a rising problem with the increases, let's say, in the metabolic syndrome and in obesity in our societies. More and more of our patients have microvascular disease, and this is something you can also quantify by PET flow. So early studies looked basically at the relationship between flow and coronary artery disease with increasing levels of percent stenosis. This is an example with oxygen 15 water. And on the left side of your panel, you see in the black circles, the stress flow values that basically decrease with increasing levels of coronary artery disease. And on the right side of your panel, you see the myocardial flow reserve, which show a similar inverse correlation with increasing percent stenosis. The same is true with ammonia, and this is basically the same concept. On the left, you have the stress flow values, and on the right, you have the flow reserve values, and you can see that with increasing levels of stenosis, you have decreased values in the flow metrics. So the majority of the data that's really used with flow ends up being related to outcomes. And this is the initial study that described outcomes looking at N13 ammonia and myocardial flow reserve tertiles, basically showing you that the patients with the lowest tertiles have the worst outcomes. This is another study that then looked at the same principle, this time using rubidium 82 chloride, but correcting also for underlying relative perfusion. And I think this is something I'll also stress as I progress in the presentation, which is ultimately no one's going to suggest that the myocardial blood flow quantitation will replace relative perfusion. It will be additive, and it needs to demonstrate value as an additive tool. And this is what they demonstrated here, but again, for outcomes. And you can see that regardless basically of your relative perfusion, total perfusion deficit, that having a myocardial flow reserve, in this case, they looked superior or equal to 2 or inferior to 2, leads to worse prognosis. This is a study by Dr. Murthy when he was working in Dr. DeCarli's lab. And this is, again, looking at outcomes, but this time corrected for essentially everything you can imagine you can correct for, including left ventricular ejection fraction, reserve, and still demonstrates that there's an additive value in terms of prognostic risk stratification of adding flow reserve to your patient risk stratification. So a few words on F18F-Flurpiridaz. So here in Canada, you guys have rubidium, so maybe we can focus on the last two columns. So rubidium is generator produced. It has a positron range of 8.6 millimeters that we'll talk about a little bit more. It has an average really image resolution when you think about it, and it has an extraction fraction of 65%. The extraction fraction is a critical value because it has a direct effect on your defect resolution. And you want to have an extraction fraction that's as high as possible. It's usually always done with pharmacological stress. There's been 1 or 2 papers actually from Ottawa describing that exercise stress is also feasible with rubidium in the scanner, but it's never used clinically. So for all intents and purposes, rubidium is only done with vasodilator stress. So Flurpiridaz is fluorine 18 labeled. It has a half-life of roughly 2 hours. It's produced by regional cyclotrons. The positron range is 1 millimeter. It has a high image and defect resolution, and the extraction fraction is 94%. And given its half-life, it's readily amenable to treadmill exercise stress, just like we do with the SPECT perfusion tracers. So Flurpiridaz has been evaluated in phase 1 to 3 trials. The principal investigator of all these trials was Dr. Madahi from UCLA. I'll just focus on the last phase 3. The results were presented at the last ASNEC meeting, if some of you were there. And basically, it met its primary and secondary endpoints. Its primary were diagnostic accuracy criteria set by the FDA, and the secondary endpoints were superiority to SPECT. The results haven't been published yet, but were presented at ASNEC. So regarding the blood flow quantitation, we derived the first blood flow quantitation in humans in 2014. I was a trainee at the time, and I really would like to highlight the person on the left, Dr. Henry Wong, who's a biomathematician, who really taught me a lot about kinetic modeling, etc., concepts that were totally foreign to me at the time. And he's actually been critically involved in modeling also with ammonia and with rubidium. And a fantastic person, really a great scientist. And the person on the right is Dr. Madahi, who is a nuclear cardiologist that many of you know. So this was a small study that we did in, I think it was like 15 or 16 patients, something like that. Half of them roughly with CAD, half of them without. And this is just to show like a proof of concept, a feasibility approach that you could quantify, and you could distinguish basically between low likelihood patients of CAD and those with known by invasive angiography CAD with either less than 50% stenosis or superior equal and 50% stenosis. And you can see that there's a progressive decrease in myocardial flow reserve. So what we highlighted in that paper that was published in 2014 is that given the properties of the tracer and the radioactive labeling, that this tracer would probably be suitable for segmental flow measurement. Here I'm showing you the positron range of the available tracers for, depending on the region of the world you're in, for the tracers available for perfusion imaging. And if you compare, for example, rubidium with Flurpiridaz, you can see that there's a significant improvement in terms of your image crispness, if you want, between flurpiridaz and rubidium. And that's because rubidium is a high energy positron, so it travels a long range inside the tissue, in this case the myocardium, before it annihilates and emits the 2 photons after meeting an electron. So 9 millimeters is roughly the thickness of the myocardium. So that's not going to give you very precise images. And I would propose to you that the majority of the benefit that we actually derive from rubidium, the vast majority of it is probably derived from the CT attenuation that we get, which significantly increases specificity compared to the SPECT tracers. Now with flurpiridaz, you can readily see from there that you only have a 1 millimeter positron range, so you can probably get more accurate imaging with this tracer. And this is what I highlighted here. And why do we want to do segmental flow measurement? And by segmental flow, I mean the AHA 17 segment model that we use. Is abnormality of myocardial blood flow associated with coronary artery disease that does not necessarily involve all segments within a given coronary territory. The superior image resolution of flurpiridaz may allow accurate measurement of blood flow at the segmental level. You can think of it akin to like the way we interpret a relative perfusion scan. If you have something, for example, a perfusion abnormality, let's say in the apex or in the apical anterior segment, you don't average it visually with like the normal basal and mid anterior segments. You still call it abnormal over a small territory. And this is kind of the same principle. We argue that like measuring flow over a segmental level may increase your diagnostic accuracy. So we reported this in a paper that was published at the end of last year. And the questions we had are the following. What is the precision of segmental values in normal patients? What is the diagnostic performance of segmental versus entire coronary territory flow using stress flow and myocardial flow reserve for CAD 50 and 70% stenosis detection? And what we think is important from a clinical standpoint is there an additive contribution of flow metrics to relative perfusion? Because again, this is not going to replace relative perfusion. So other than for prognostic risk stratification, we need to demonstrate that we're gaining something from doing this in addition to the relative perfusion reports we always provide. So the study was derived from the phase 301 clinical trial of flurpiridaz, and I will just highlight that of the 557 patients who underwent farm stress, there was also an exercise stress arm, but we focused on the ones with pharmacological stress because we want to quantify blood flow. Roughly only half of them were suitable for analysis, and you can see from the top arrow that over 200 of them were missing or had inadequate kinetic data, and then the others were excluded for reasons that I present here. And there, I might add also that flow quantification was not an endpoint for the 301 trial. That's why people didn't look at it that carefully and sometimes started acquisition after the tracer was injected. So the flurpiridaz doses were pre-specified as 2.5 to 3 millicuries for rest and 6 to 6.5 millicuries for farm stress. And there was a 30 minutes or greater delay between rest and pharmacological stress. And everything that I'm presenting underwent blinded quality control and processing data. The invasive angiograms were done by a core lab, also completely blinded. So the method we used was based on our previously published study. It utilizes the early, and I'm not going to show you equations because that doesn't serve any purpose, but briefly, it utilizes the early kinetics of myocardial uptake of flurpiridaz. It assumes that within the first minutes post-tracer injection, there are few, if any, F18 labeled metabolites in the blood. It takes advantage of the 94% extraction fraction of flurpiridaz. It accounts for the partial volume effect and the spillover of activities, and it deems the tracer binding irreversible, meaning from a modeling standpoint, it uses a one compartment model. These are the patient characteristics. They have basically an expected distribution of cardiovascular risk factors. The LVEFs for the most part were normal because cardiomyopathy patients were excluded from the clinical trial. So we actually looked, and I discovered the multiple ways by which you can measure accuracy based on the reviewer comments I was getting and talking frequently with our biostatistician. This is one of the 3 that we did, looking at variance. And bottom line of the story is that on the top row, you have the territory precision, and at the bottom row you have the segmental precisions, and we want to make sure that there wasn't increased noise in the system, and the values are very similar between rest flow and stress flow, and there's no statistically significant difference between these. So the precision you obtain using Flurpiridaz for segmental flow measurement or territory flow measurement are similar. So this is now what we want to look at in terms of diagnostic accuracy. And what you're seeing, I'm going to walk you through this slide. It's pretty busy, but this is a summary of like multiple ROC curves. So these bars that you're seeing, every single one represents the area under the ROC curve. Instead of showing you the curves, I'm showing them in bar graph format so that it's more kind of comprehensible. And we're comparing directly flow metrics with perfusion quantitation. The perfusion quantitation we used here is a method we developed and validated of automated relative perfusion quantitation. So there's no human factor here. I mean, there is in the sense that like you can correct for certain things, but like it's not a visual interpretation what I'm getting to. It's a software quantitation which we validated and which removes kind of any potential bias. So to obtain a CAD 50% diagnosis, and you could be like, why are we looking at CAD 50% when we know that most lesions have to be 70% or greater to have hemodynamic significance? Well, the reason therefore is actually because it's an FDA requirement. Turns out that the FDA, to approve anything for CAD, wants to, from an imaging standpoint, you need to be able to diagnose CAD 50% or greater. So the diagnostic accuracy of perfusion quantitation is 0.73 to detect CAD 50%. Then we're looking at segmental versus territory comparisons of three metrics. SMBF is the stress flow. MFR is the myocardial flow reserve that I described earlier. And RFR is a metric that sometimes is used, not commonly, but it's sometimes used, which is relative flow reserve. And it's basically most similar to really invasive fractional flow reserve. And basically it normalizes, it divides like your stress flow in the abnormal segment with the one with the highest territory. And we did that, we derived a metric therefore also for segmental relative flow reserve. Again, the ones that are commonly used are like stress flow and myocardial flow reserve. So the first thing you can see is that your flow metrics have a similar diagnostic accuracy with perfusion quantitation other than territory RFR. So the performance of your flow metrics are similar. The second thing that you can see is that for every single comparison, red segmental, blue territory, you can see that segmental flow metrics are superior to territory metrics by approximately 3 points. And then the other thing you can also see is that your stress metrics, I'm sorry, I can only point to one area, so just follow the text. But if you look at the SMBF segmental column, which is the first red column, you can see that it's superior to MFR segmental measurement and RFR segmental measurement. And the same is true for the first blue column you see, which is the SMBF territory, which is superior to MFR territory and RFR territory. So what this means in summary is that for CAD 50% diagnosis, perfusion and blood flow metrics perform similarly. If you look at blood flow metrics only, segmental is superior to territory regardless of the metric. And the third thing it means is that stress flow, whether segmental or territory, is superior to myocardial flow reserve for detection of coronary artery disease. Now, this is looking at CAD 70%, and you can see now that you have a significant increase in the diagnostic accuracy of perfusion quantitation alone, which is the yellow bar, and it's around 0.85. If anyone is interested in discussing why these numbers aren't actually higher, I'm happy to discuss that because a lot of it had to do with the clinical trial design. And now you can see that your perfusion quantitation for CAD 70% is basically superior to all the flow metrics other than this new metric that we propose in this paper, which is segmental RFR, which we don't need to discuss in detail. But just keep in mind that at 70% stenosis, perfusion quantitation does better than any of the flow metrics to diagnose significant coronary artery disease. However, you again can see that regardless of the permutation, segmental flow metrics are superior to territory flow metrics, whether stress flow, myocardial flow reserve, or relative flow reserve. So then the question is given that there was no significant difference between the performance of perfusion quant with the flow metrics at greater than 50% stenosis, but there was at 70%, we wanted to look specifically at the 50 to 69% range. And here you can see that basically perfusion quantitation was basically superior to that. The perfusion quantitation, didn't do as well as the territory stress flow and the segmental stress flow. So the first red column and the first blue column did better than perfusion quant. That's the main thing that I'd like you to take away from this particular slide. Now we want to look at the per vessel diagnostic performance to understand what is really driving this improvement. And as you know, the LAD has 7 segments that categorize the territory, and you can see that there's a very significant improvement that's really driven by the LAD territory. There was no significant difference in the left circumflex territory, and there was a minor contribution by the RCA territory for CAD 70% detection using stress flow. The same was true for myocardial flow reserve. The majority of the benefit is driven by the LAD territory, some by the RCA, and none by the left circumflex. So now the question is what, that we want to address is what I mentioned at the very beginning. We know perfusion quantitation works, relative perfusion quantitation. Now the question is, if we add any of these flow metrics, do I gain any improvement in diagnostic accuracy? And what you can see here is that the plus sign means that it's like a method by which you can combine, so to speak, the diagnostic accuracy of both tests. And you can see that when you add either segmental stress flow, SMBF, which is the first red column, or if you add territory stress flow, which is the first blue column, that you have a significant improvement in the diagnostic performance of your test beyond relative perfusion quantitation. None of the other parameters were contributing to this improvement. This was not the case for CAD 70%. So if you're detecting a CAD 70% lesion with your relative perfusion, adding the flow metrics does not help improve your diagnostic performance. And this is similar to what I was showing earlier, which we wanted to really zoom in on the 50 to 69% range. And you can see really, if you focus just on that area, meaning you ignore the 70 to 100% data that you have, and you consider quote unquote normal studies as 0 to 49% stenosis and the abnormal ones as 50 to 69%, you can see that your perfusion quant alone is basically barely better than like guessing. And like adding segmental flow and stress flow, segmental stress flow or territory flow helps improve your diagnostic performance. So in conclusion, the precision of coronary territory and segmental stress flow and relative segmental stress flow and rest flow is similar. The diagnostic accuracy of segmental stress flow and myocardial flow reserve is superior to the territory stress flow and myocardial flow reserve. And only segmental or territory stress flow provides additive discriminatory power for CAD 50% categorization when combined with relative perfusion. These are the folks I'd like to thank who have taught me a lot and continue to teach me a lot. And maybe during the discussion afterwards, I have a few cases if anyone wants to look at a few cases. Thank you for your attention.